Good afternoon, ladies and gentlemen. In this 8 minutes presentation, I would like to guide you through the mysteries of differentiated thyroid cancer. My name is Máté Orgoványi. I'm a third-year internal medicine resident here at the Uzsoki Hospital, Budapest. And with my precious team, we wish a better management for differentiated thyroid cancer patients due to the mission to provide evidence-based knowledge, which would be investigating the predicting accuracy of different risk factors of papillary thyroid microcarcinoma and investigating the radioactive iodine treatment as a risk factor for second primary malignancies in differentiated thyroid cancer patients. My first project will be done by the methodology of systematic review and meta-analysis. The number of the papillary thyroid cancer are rising, however, the mortality remains stable. The reason behind this phenomenon is the better ultrasound images, because we can detect tumor under the size of 1 centimeter, which the literature calls microcarcinoma. As you can see from the death rates, the papillary thyroid cancer, including the microcarcinoma, is a very indolent disease, and that was the reason that the active surveillance came to fore firstly in Japan instead of the immediate surgical procedure. Unfortunately, there is a certain percentage that the tumor will progress, which means at least tumor size increase at least 3 millimeters, or appearance of novel lymph node metastasis or exathyroid manifestation. According to the current knowledge, we don't know the risk factors of progression, so our aim to investigate these factors associated with worse prognosis in PTMC patients. From a clinical approach, I would like to demonstrate a case of a 65-year-old female singer where we performed a ultrasonography and we detect a thyroid nodule with a suspicion of malignancy, and after the fine needle aspiration cytology, the result came back that it's a papillary thyroid microcarcinoma. Based on the current guideline, the active surveillance would be an excellent treatment option, but if we know the risk factors, maybe we can prevent on time the progression with personalized interventions. Based on these, our clinical question would be which factors elevate the risk of progression in papillary thyroid microcarcinoma. We would like to use the PFO framework, which means the P is the population patients with PTMC, the F is the risk factors, which we separated into 2 subgroups, modifiable and non-modifiable factors, and the O is the outcome, which would be tumor size increase, lymph node metastasis, or exathyroidal extension. Our hypothesis would be that certain biomarkers are associated with the progression of PTMC with the clinical implication to avoid under-treatment. I have collected all my key articles, and luckily most of them are prospective qualitative studies with high-quality data. We can assess more variables, but there are some limitations. For example, in these studies, there was a different age interval, and it can be really hard to interpret during the statistical analysis. For our search protocol, we needed to modify a little bit, but it still consists of 1 domain which describes the population. The systematic search was conducted in 3 databases, and here you can see the number of the results. Altogether, we find almost 6,000 articles, and after the duplication removal, we are already finished the title and abstract selection. I can show you some preliminary numbers for our full text selection. Approximately 500 full text will be waiting for us to analyze it. And in this slide, you can see my progress. My second project focuses on the carcinogenic effect of radioactive iodine treatment as a risk factor in differentiated thyroid cancer patients. The DTC, which is the differentiated thyroid carcinoma, is the 9th most common cancer worldwide, and luckily we have a perfect treatment, which is the radioactive iodine therapy. During this treatment, with the help of the sodium iodine contrasporter, the cells uptake the radioactive iodine, which is a radioisotope, and it is because it's a radioactive material, it has a beta radiation effect, and it will cause the DNA damage, and it will help us during the treatment. Unfortunately, there are other organ systems which can also uptake these isotopes, and it has the possibility, that the occurrence of second primary cancer. Despite the fact that this treatment has tumorigenesis effect, the adjuvant or ablative radioactive iodine treatment improves overall and disease-free survival in this population. Our aim to examine the occurrence of second primary tumors after radioactive iodine treatment. Our clinical question would be, does radioactive iodine treatment elevate the risk for developing second primary malignancies in DTC patients? We would like to use the COCOPOP and the PICO framework. The context and the conditions would be second primary malignancy and patients treated by surgically and radioactive iodine treatment. And the population would be, of course, the DTC patients. And in the case of the PICO, it would be the same, but the comparator would be just the DTC patients with surgical treatment. I have collected all the key articles, most of the studies from the national databases. Some of them examined the dosage, which would be really beneficial for our further knowledge, but of course there are some limitations also. Here you can see our preliminary search protocol, our preliminary search key, and below you can see the number of the hits. Summarizing what was heard, if we manage to prove our hypothesis, we can make easier and better decisions during our clinical practice, and hopefully on the next progress report we can solve together these mysteries, which still I don't know these results. In the end, I would like to close my presentation with the words of Zora Hurston: research is formalized curiosity, it is poking and prying with a purpose. Thank you for your attention.
Thank you very much, Máté, and I would like to ask the audience if there is any question. Please.
Yes. Thanks for your presentation. I would like to ask that what are the experiences, how the patients accept the active surveillance treatment?
That's an interesting question, because here in Hungary we don't use the active surveillance. They use it in the Asian countries and mostly in America. My personal opinion that it's really hard as a doctor to do nothing, because the active surveillance is, we actively do nothing. This is the definition of active surveillance. And it's not easy for the patients, because I will tell the patient that you have cancer and it will be there. Thank you for your attention. So it's really hard. It can cause, the patient can be anxious, depressed, and I think it can be a really good risk factor, because we can know that psychosomatic diseases are valid and it's among us here. So that's a tough question, and there is no evidence for this. I've already read some studies about the quality of life. Luckily, most of the patients can accept this treatment, but some of them choose the surgical treatment.
Thank you.
Thank you. Another question?
I would like to know what kind of cancer can occur after radioactive treatment?
Most of them was hematologic disorder, acute myeloid leukemia, but it can be MDS, myelodysplastic syndrome, and it can occur the cancer of the urinary tract.
Another question?
Hello. So it's funny because we work in the same hospital. So just if we have to discuss the patient about operate or not to operate, we have to tell to the patient that about something with the recurrent nerve paralysis, and
Yes.
after that we can make an agreement on this. And in the second part, is there any kind of histologic factor which can predict the worst prognosis, or maybe in general we use the aspiration or with a biopsy or a bigger tissue sampling technique? Could we reach any more information about this?
Yes, the papillary thyroid cancer has, if I know well, approximately 10 histologic subtypes, and there are some really malignant. We just performed fine needle aspiration cytology. The biopsy is not needed because if we decided to do the surgery, it's a protocol that the pathologist has to search and examine all of their thyroid gland. So the core biopsy is not needed. According to my supervisor, it's almost 90% that it's the is a papillary classical papillary variant, and during his 20 years of practice, he never saw any type of other subtypes.
Thank you.
Please, any other questions?
Thank you. So there are several risk factors in your first project. After looking through more than 500 articles, what is your impression? What are the most investigated ones among them?
Like the age, the younger age, it would be a risk factor. The multiplicity, there's more than one tumor in the gland. The localization, that it's bilateral or unilateral, it can be also. It's tough because we don't know that the lobectomy or the total thyroidectomy is the preferred surgical type technique. It's very interesting because as I see, the Hashimoto thyroiditis, it can be not a risk factor. And it's really interesting because we know that the Hashimoto thyroiditis can cause lymphocytic lymphoma in the thyroid gland, but it seems that in this case it can be a protective factor.
It's interesting, thank you. And one question to your second project, what is the usual length of this iodine treatment?
Well, it depends on the stages of the tumor and the histologic type, because we can use on the papillary type, follicular type, medullary type carcinomas also. It depends on it's an adjuvant or an ablative treatment. Mostly 1 or 2 iodine treatments is enough, but sometimes it's needed more.
And what is the ideal follow-up to detect this second primary?
There is no protocol for that.
No protocol?
No, not at all.
I also have one question. Why is 1 centimeter the cutoff size for microcarcinomas, and is it like a uniform, everywhere accepted, or
it's
there are variations? It's
everywhere accepted, and that was the question of my supervisor also, but I told him that we can't answer this question. Yes.
Okay.
It's the active surveillance, and this 1 centimeter came from Japan. It was a big study with big populations, and they told us that 1 centimeter is 1 centimeter.
Understood.
We can accept it.